Hello, my name is Miss White and welcome to Chapter 12. Today we'll be talking about alterations in somatic and special sensory function. So as I've mentioned, we'll be talking about your sensory alterations. So that'll include touch, which is indicated by pain, hearing and balance, vision. We'll even talk about taste and smell. Here's a good overview of your sensory alterations. As we go down our lecture or go through our lecture, you'll see bits and pieces of this and why they are alterations. So the first thing I want to talk about is your somatosensory system, and this is your sensation. More specifically, this is dealing with your touch and how your body responds to the outward environment or the outside environment. So we do have different sensations. We have pain, which is also known as nociception. We have touch, we have temperature, we have body position, which is kind of a peripheral way of feeling sensation. So that's proprioception. So all of these sensations help relay information from the outside environment, which is through our periphery. And again, that could be our skin, that could be our fingers, and it helps sends those stimuli to our central nervous system. And we have different pathways that help with that. We have sensory receptors that are located on these areas of the body. We have pathways that help direct all of these stimuli sensations to the brain. And then inside of the brain, we do have processing centers. So we do have neuronal transmission, and again, these are areas where we have an outside stimulus that transmits these stimuli through neuronal impulses and helps to transmit those signals to the brain. So we have two different pathways that help to do that. The first pathway is called the discriminative pathway, and these are very specific, and it helps communicate sensory information, including touch and spatial orientation, which is very specific, versus the anterolateral pathway, which helps basically do everything that's not requiring specific location of the origin of the stimulus. So this differs from your discriminative pathway because it's not necessarily specific. You do have other areas that help you decipher what's going on with your stimuli. You have temperature, you have crude touch and pressure, but it does not necessarily tell you the specifics of the location and the origin of your stimulus. So the discriminative pathway is very specific to what that stimulus is, whereas the enteral pathway, it does everything that helps necessarily refine it, but again, it's not a specific area. So once your body gets the stimulus from the outside environment, it does process through those neuronal pathways, whether it's the discriminative pathway or the anterolateral pathway. Both of those pathways lead to the processing in the thalamus. Again, this is an area in the brain that helps you with awareness, recognition, identification, and the interpretation of stimuli. So with our alterations, if you do have brain damage, it's very possible that if your thalamus is injured, then your sense of sensation and recognition and even crude touch or specific touch is altered due to the damage in this area of the brain. It's also important to note that when we have sensory stimuli, there's different modalities that we have with our stimuli. Again, we have the different acuities, how severe it is. We have thermal, so that helps differentiate between hot and cold. You have positioning that helps you determine your stimuli. And then just basically with tactile or touching, you have different pressures and vibrations that help send stimuli to your brain to help you feel those sensations of feeling. So normally when we have injury to the body, such as in the case of inflammation, one of the tall tale signs of inflammation is pain. Well, pain is also known as nociceptive sensory modality. So basically what this means is that this is a stimulus that originates on the outside of the nervous system. So again, this is happening on the outside and sending those stimuli to the brain. You also have other types of pains such as neurogenic pain or neuropathic pain. And this type of pain originates within the nervous system. So just like when you touch a hot stove, that would be considered a nociceptive pain because that stimulus is on the outside of the nervous system and sending those signals within to your thalamus and your brain. Whereas neurogenic or neuropathic is different because that stimulus originates from within the body and sends those pain signals. So it's within that same system that you feel this pain. we'll be talking about the conduction of pain sensation. So once we feel pain, it travels and sends a signal to the central nervous system. So again, you have to have some type of noxious stimuli. And when we talk about noxious, that's something that is a stimulation, or it sends that signal of pain to the body. And you have several types of stimuli. You can have chemical pain, mechanical pain, or thermal pain. Again, these will all send a signal to the brain that something is wrong and something is happening to the body. You can even have, because of that neurogenic pain or neuropathic pain, you can have that originate within the body and still send these same signals. So again, the conduction of pain remains the same regardless of if it happens on the outside of the body or the inside of the body. So once you have that stimuli, it transmits from tissues to the central nervous system, and more specifically, it transmits from the periphery from which that stimulus is conducted to that central nervous system, and it goes through to the brain and the thalamus. And you do have different fibers that help send the pain sensation. Those are known as type A or delta fibers, and you have type C fibers. Regardless, these help stimulate the autonomic and the reflex responses in your nervous system. As far as modulation, this is how the pain sensation travels and it continues to grow. And there are substances that are released during the impulse transmission that help your body determine that it is in pain. Once that modulation occurs, you have the slowing of the rate of impulse transmission. And then finally, you have the perception, which is when the brain finally makes the connection that from the stimuli that it has received to the brain that you have experienced some sort of pain. And that happens through the somatosensory cortex in the brain. And that's the sensory section of it. And then you have the emotional segment, which involves your limbic system. So normally when you have pain, you may have some type of sensory response, which hurts. That's the sensory response. But then you have an emotional response, which you may start crying, you may have tears, you may shout. All of these are examples of emotional involvement when you have the conduction of pain. And here is your concept map regarding that pain. So you have tissue injury, which leads to inflammation. As we've learned in previous chapters, one of the tall cardinal signs of inflammation is pain. So once we have pain, that releases your mediators, in particular substance P. We have serotonin, acetylcholine, and your prostaglandins. That sends a signal to your receptors, and that receptor clings your signal all the way through your spinal thalamic pathway. Again, goes through your spine to the thalamus, and then it helps to send that signal to the primary somatosensory cortex, which tells your body that you're having pain. So here we have different theories of pain. So we talked about how pain is transmitted and how we have stimuli that helps to tell the brain and the thalamus specifically that you are experiencing pain. And we also talked about the sensory portion of that versus the emotional portion of that. But there are different theories that are regarding pain. You have the pattern theory, specificity theory, intensity theory, the neuromatrix theory, and finally the gate control theory. What I want you to really focus on is the gate control theory, because it is one of the most well-known theories on pain, and it helps represent the explanation for pain that unites different principles that help with the specificity of pain. So with the gate control theory, you have your peripheral receptors, or your receptors that receive that stimuli, and those stimuli travel along your afferent neurons and enter the spinal cord, which helps travel to the spinal thalamus pathway. That spinal thalamic pathway goes to the gate, and that gate regulates your impulses of pain. So really what it proposes is that when you're stimulated with pain, your alpha fibers, your beta and alpha fibers, they close the gate once you have pain, and it helps to further inhibit the pain impulse because you've already experienced pain. So once that pain hits your brain, basically, it doesn't allow the continuation of that stimulus. In fact, it helps close it off or gate it off. That way you don't continue to get that modulation of pain. So ultimately, once that pain is blocked, you have the diminishing pain perception. So the gate control theory just basically says that once you experience pain, your body tells itself to close the gate once you receive those impulses to help further decrease that pain at a later time. As a nurse, you have different areas of pain that you have to manage with an individual. Again, you have that nociceptive pain that's outside stimulus that's providing pain, but you also have to deal with neurogenic pain and neuropathic pain, and even idiopathic pain, which has no known cause, right? So we have different classifications of pain, and what you can look at this as your way to help assess what type of pain that your patient is experiencing, and ultimately help you divide what's going on with the patient and maybe help to treat that pain better. So the first thing you want to look at with pain is the location. You have cutaneous pain, which is on the skin, of course. You have deep pain. You have visceral pain, which normally involves the organs, and you have referred pain. And again, that helps with where they're saying that it is. So they may tell you exactly where it is. And then you want to assess the quality of the pain. So it could be diffuse, it could be throbbing, stabbing, sharp, burning. Any of those detailed quality descriptors would help tell you about what's going on with the pain, and it also would help you to manage the pain. And then you want to look at the duration of the pain. Is it intermittent? Is it acute? Is it chronic? How long does it last? These would be important questions to ask when you're dealing with your patient's pain, because this will help provide a bigger picture as to what's going on with your patient. So again, you want to look at location, where it's going on. You want to look at the quality, how do they describe it? And then you want to look at the duration and how it's affecting them. So as a nurse, not only do you have to assess for pain, you have to figure out ways to treat the pain. And sometimes that does not always include medications. In fact, sometimes you'll have to use what we call non-pharmacological methods to help treat pain, because maybe your patient has received too many pain medications. Maybe they're in the middle of their PRN and can't have any more for the next hour or two. So you have to figure out methods to help treat the pain intermittently until they can either get their next dose or until their pain has subsided. So we'll talk about a couple of ways to do that. The first is through cognitive behavioral interventions. So that is a broad spectrum of ways to do this. And again, not one answer is the correct answer, and it does depend on your patient and what they're currently experiencing. And it also depends on the willingness for them to try certain methods that don't include pharmacological interventions. So one of the first CBTs or cognitive behavioral interventions is relaxation, and that helps to lessen muscle tension, which could be an indicator of pain. You can use distraction that would help focus on stimuli that's not associated with pain. So you can have them watch TV or listen to music. You can have them look at something else that would help redirect their focus. You can use cognitive reappraisal, which is a form of self-distraction. Maybe they need to tell themselves that, hey, this is not as painful, or maybe they should talk to themselves about how their pain is and maybe help redirect that. It may even include focusing on aspects that are more positive about their experience, such as, hey, yes, I'm in pain, but at least we're figuring out what's going on so we can fix the pain. And that could help lessen the pain due to relief of anxiety. You may use a method called imagery, and that helps to create a mental picture or a mental area that is soothing to them, and that can even be recreated as their home environment. That could be a beach somewhere, or even in the mountains. You can create an imagery space for this individual. That way they can somewhat redirect their attention to what's soothing and not necessarily what's giving them pain. You can also use methods called biofeedback, and that's really awareness of your bodily function on a cognitive level. It's really determining if your body can perform certain functions in absence of the pain, or can it perform those functions with the pain there. So this involves the person's willingness. Sometimes they're not willing to say that they can do certain things outside or in absence of pain. So that would be determined on the patient. You have physical agents that you can use. Again, you can use heat and cold packs that help with pain treatment, particularly with heat. That helps increase the circulation. It helps reduce ischemia and pain reception or nociceptive reception. It also helps to reduce the modulation of pain, and it also helps to release internal opioids, and we'll talk about that. Your body self-soothes. So when you use heat therapy, it helps to self-soothe the body. You can also use cold therapy, which helps, and this kind of leads to the Rice method, of course, where you use cold compression, or ice in that matter. But you can use cold packs to help with vasoconstriction, which helps decrease swelling and also the stimulation of pain. It helps to reduce the activity of those painful stimuli from traveling up those electrical nerves, and it helps to reduce the transmission of electrical impulses from the stimuli to the brain. As far as acupuncture is concerned, that is the insertion of needles at specific points in the body, and it takes a trained professional to do acupuncture. But what it does is that it helps secrete endorphins, and endorphins are those feel-good molecules, those feel-good hormones that help the body soothe itself. And it also helps to stimulate those large fibers to modulate pain transmission and to ultimately help subside that pain. As far as your pharmacological methods, of course, you want to try your analgesics. You have two different types. You have non-narcotic analgesics, which include NSAIDs, Tylenol, aspirin. But what they do is that they help block those nerve impulses, and it ultimately helps decrease the production of prostaglandins. It helps to decrease the production of prostaglandins, and it also helps to decrease your sensitivity to histamines or those inflammatory markers. You also have opioid analgesics, and that includes fentanyl, that includes morphine, codeine, and what they do is that they help modulate pain at the level of the spinal cord, and they help release your endogenous opioids, such as your endorphins, those feel-good hormones that help you to self-soothe. You have adjuvant analgesics, and that is a therapy that is not normally used for pain but can help treat pain. For example, you have your tricyclic antidepressants. Normally those are used for depressive episodes, of course, but if a person is experiencing depression due to the pain, if you treat the depression, it helps to reduce the sensation of pain as an adjuvant therapy. It's particularly useful in individuals that have chronic pain because they tend to be more depressed due to the pain. So again, you have these different modalities in the treatment of pain, and you should know most of these because they may come up again. But again, know the differences between non-pharmacological therapies versus pharmacological therapies and the benefits of either. Next, we're talking about vision, and again, this is all about the eyes, and we'll talk about a little bit of the function of the eyes, but then we'll move into what those alterations look like. So here we have the eye, and these are just your general structures of the eye. I'm not necessarily testing you on all of the structures here, but I just want you to remember where your cornea are, the pupils, iris, lens, ciliary muscles, chamber, and retina. So just make sure you look at this photo and just kind of remember where your areas are here. So the main function of our eyes is to help us see, but the way we see is through the bending of light, also known as refraction. So anytime that our eyes are unable to bend light or refract, well, we'll see alterations or errors in our seeing. So we have several different types of that we'll discuss today. The first one is called myopia, and most of you may know this condition as nearsightedness. And in those individuals that are nearsighted, they can see objects that are are further closer to their eyes than they can that are farther away. So in myopia, the images or whatever the person is focusing on must be closer to the eyes in order for them to see. So the issue with this is that the eye is focusing on the image in front of the retina due to the lens thickness. And in order to correct this, you have to have concave lenses that help the light to diverge, which ultimately corrects the myopia. So the next one we have is hyperopia, and this is the opposite of myopia. So you have myopia, that's nearsighted. Hyperopia is farsightedness, and that is an individual that can see further away than they can up close. And this is because your eyes are focusing on the image behind the retina, which alters the transmission of light. So you have to have a convex lens in order to correct hyperopia because it causes your lights to converge. As you see here in this photo, when you have myopia, the image is in front of the retina, whereas when you have hyperopia, the image is behind that retina. So again, you need a convex lens to fix hyperopia, and you need a concave lens to fix myopia. The next one we'll talk about is called astigmatism, and a lot of you may have heard of an astigmatism, and many people have these, but this is an irregular curvature of your cornea or lens, which prevents the focusing of your images. Ultimately, this is where your blurred vision comes from. So again, a lot of people that have glasses have blurred vision, and that blurred vision is known as astigmatism. So you can correct astigmatism through several modalities. You can use glasses, you can use contact lenses, you can use laser surgery or LASIK surgery, several modalities to help fix that. And it's a quite easy fix. And then you have presbyopia, and this is a condition of farsightedness, so it's a subset of hyperopia, but it's a farsightedness that is a result of aging. And this is a physical barrier because this is dealing more specifically with age. Not necessarily young people have presbyopia, they have hyperopia, but as you age and get older, you get something called presbyopia. And again, this is when you age. And it is corrected with bifocals, but this is one of the reasons why you see the elderly with those thicker glasses, because they can't necessarily change the physical aspect of their eyes deteriorating. So this is the condition that presents itself. So we talked about the alterations in vision, but let's talk a little bit about the alteration in the movement of the eye. So we have the first one, which is called strabismus, and strabismus is also known as cross eyes, but it is the lack of coordinated eye muscle movement that prevents your eyes from lining up in the same direction, hence cross-eyed. So one of your eye pupils will be looking one direction and the other one will look another direction. We have amblyopia, and this is known as lazy eye. And again, this can be a subset of strabismus, but again, you have that uncoordinated eye movement, and ultimately you have that loss of focus. So you can have one eye that's perfectly fine, but then the other lazy eye, as they would call, is uncoordinated, and the eye movement is not there, and you cannot focus with that eye. You have diplopia. And this is a eye condition that may result in double vision. So your eyes don't necessarily move in the same direction. And the visual defect here is that there's, again, no coordination of your extraocular muscles. So your eyes are moving, they're shifting, but it's not coordinated enough for you to be able to focus. Hence, that's where you get your double vision. And the last one you have is nystagmus, excuse me, I can't talk today. Nystagmus, and this results from abnormal functioning in the brain. So this is more of a neurological issue, but basically the part of the brain that's responsible for controlling eye movement has been altered, or your brain is no longer able to control it. So you have these involuntary oscillations or movements of the eyes, and you're not able to control it. So that is called nystagmus. So again, you have the differences here: strabismus, amblyopia, and diplopia. those are more focused on lack of coordination in the movement, but the brain is still working, whereas nystagmus is completely a brain alteration and you are not able to control any of your movements at all. So next we'll talk about some alterations in the protective structures of the eyes. So we'll be talking about conjunctivitis and we'll be talking about cataracts. So there are three types of conjunctivitis. You have viral, bacterial, and allergic. So you should know the differences between these three types of conjunctivitis because they do have slight differences. They have the same result, but a little bit differences here. So viral conjunctivitis only affects one eye, and that eye is normally watery, and you have small amounts of discharge, but again, viral conjunctivitis is normally affecting one eye. And if you're not aware of what conjunctivitis is, but that is a pink eye. So again, viral conjunctivitis only affects one eye, whereas bacterial conjunctivitis, it affects both eyes and it has heavy discharge. So again, viral conjunctivitis, one eye minimum discharge, whereas bacterial conjunctivitis has both eyes affected and you have a heavy discharge. Allergic conjunctivitis is triggered by an allergen, of course, but it normally affects both eyes and you have more symptoms such as itching, redness, and excessive tearing. So make sure you understand the differences between the three types of conjunctivitis. You have different types of cataracts, and the most common type of cataract is called the nuclear sclerotic, and that normally forms in the center of the nucleus of the lens, and of course it causes variations in your vision, and it is the most common type. When you have a nuclear sclerotic cataract, your distance vision is more affected than your near vision. So you're not able to see far distances, but you can see up close a little bit better. The issue with this one is that there is a slow progression of this type of cataract. Again, it is associated with aging, and there is a very slow progression of this. The next one we have is cortical, and these cataracts form in your lens cortex, and it extends from the outer lens towards the center. You don't necessarily have a lot of vision impairment. You have some, but it's not as severe as that of the nuclear sclerotic. You have the posterior subscapular, and this begins at the back of the lens, and it results in a halo effect or glare around eyes. So this is a type of cataract that produces that glare or halo effect within the eyes, and this is rapid in its progression. It can happen within months compared to that of the nuclear sclerotic, which happens in years, and again it is associated with aging. So make sure you know the differences between the three types of cataracts and the three types of conjunctivitis. So next we'll talk a little bit about our diagnostics for our eyes. So most of you may be familiar with the Snellen chart or the E chart, and that's the chart that they make you read at the eye doctor, and it tells you which letters at certain levels, and the letters get smaller and smaller. Well, what they're trying to report is a fraction which helps tell what your distance average reading is. So normally you have 20/20 vision, which is what an average person can see at the distance of 20 feet. So if you have 20/20 vision, that means you're at goal. You are where a normal person should be able to read at a distance of 20 feet. Whereas if you have 20/60 or 20/40, what that means is that what can be seen clearly at 20 feet, you see at 40 feet or 60 feet, which is not necessarily a great thing. And what it does mean is that you need some sort of corrective lenses. The next one is the Jaeger chart. And this one is more so used for far distance. So you have a chart that's placed about 12 to 14 inches away, and you're asked to read the smallest of the 10 available lines, and they have different font sizes. So once you read that, it basically gives them a score, and then they convert that to your Snellen chart readings of 20/20 or 20/40, etc., etc. So The Snellen chart is more so used for near distance testing, whereas your Jaeger chart is used for far distance testing. Now, as far as your treatment of alterations, you have different corrective modalities. You can use glasses, you can use contact lenses, you can use patching, which would help curve that area that is not doing well in your lens, or you could have different types of surgeries. You can remove the cataracts, you can have LASIK surgery, or you can even treat the glaucoma with different types of medications. So these are your different components of vision screening. Of course, they use your acuity distance, and that helps to relay how sharp or clear you can see at 20 feet of distance, which is your average. When you are acuity near, you have clear vision for a short distance, as in reading. When you have focus skills, you have various tasks that you're completing, and you maintain clear vision at varying distances for focusing. You have eye tracking and fixation skills. You have binocular fusion, which is the ability to close your eyes together. They may look at stereopsis, which is the binocular depth perception. They may look at your convergence, where your eye can coordinate, and if they can't coordinate, do they how much do they not move as a team, or how much do your eyes not move together? So they'll look at that as an area to assess your screening. They will look at hyperopia. Again, that's where your difficulty focusing on near objects. You can see farther away, but you can't see near. They'll look at color vision, so they can see if you can distinguish different colors. They may even look at your reversal frequency. So are you able to decipher and distinguish between difficult letters, such as the difference between P and Q, or B and D, or saw and was? And it may even lead to a little bit of assessment for dyslexia. Visual memory, are you able to look at something and actually retrieve and store that visual information from what you saw? They may look at your form discrimination, which is the ability to determine whether two shapes or sizes or positions are the same or different. So again, are you able to tell the difference between different pictures and images once presented? They'll look at your visual motor integration. So are you able to put your visual input based off of what you touch, feel, and see? So are you able to discriminate based off of external stimulus with or without looking? And they'll also look at your intraocular pressures. So normally you want a pressure in your eyes between 10 and 21 millimeters per mercury. What normally helps maintain that is your aqueous humor. So your aqueous humor is not only a nutritional factor to help keep your eyes nutrient in the cornea and the lens, but it also helps to maintain pressure and that intraocular pressure at that. So again, these are just different components of screening, and these are different areas that they look at to tell if you have any issues or no issues with your screening. If there are issues with your seeing or your visual, you'll see these types of visual manifestations. You may see changes in the vision altogether. You may see decreasing acuity. You may see decreasing clarity. You may not be able to distinguish colors that well, or shapes, or even when we were talking about distinguishing the differences between different letters, you may not be able to do that anymore. So if you have any changes in your vision, that would prompt one to see an eye doctor, an ophthalmologist, just to make sure there's no vision alterations occurring. So next we'll talk about hearing, and again we'll talk a little bit about the function of hearing, of course, which is to make sure you hear sound, and then we'll go into a little bit of the alterations. So here it's good to know that your hearing involves the integration of neuronal impulses and the function of your ear structure. So really what happens is that you get a sound stimulus, and it goes through that tympanic membrane, and it helps send a signal to your brain to let the brain know that you're hearing, and it helps you decipher sounds and everything. So when these structures are damaged, such as your middle ear or your tympanic membrane, the internal ear, that's where you see your alterations in your hearing. So as we've mentioned, your hearing is a combination of outside stimulus and a combination of a neuronal signal to your brain. Well, what helps with your neuronal signal is that acousto-cranial nerve, such as cranial nerve 8. And what it does is that it helps relay messages to that midbrain center, and then it helps with your dual pathways with the right and left auditory cortex. So again, when you're hearing these stimulations from the outside environment, your neuronal signals, your acoustic nerves are working in tandem with your brain in order to help you hear. When you have brain damage and your cranial nerve damage here, that's where you'll see manipulation and alterations in your hearing. A lot of our hearing also has to do with our vestibular function, and it also helps with balance. So anytime we have issues with our ears, we see issues with our balance processes. But just as a little bit of a A&P for this, when we have motion from body movement, it is detected by hair cells within the ear. Particularly, it's in the semicircular canals, the utricle and the saccule, and your organ of corti. Once that hair cell is stimulated, that neuronal signal is transmitted to the cerebellum via your vestibular branch of the acoustic cranial nerve, and then that's where you hear, where you have balance that is processed. When these areas are damaged, you may see some issues with balance with these individuals. And there are some integrations with the vestibular nuclei. You may see some visual input, somatic input, which is your touch and sensory there. And it does modulate to the eye and ultimately your reflex. So again, when you have balance and vestibular function and alterations of that is more than likely caused by some sort of damage in these areas, particularly in your cranial nerves, in your cerebellum, or areas of that nature. Okay, so next we'll talk about the alterations in hearing and balance. And again, this is about location within the ear. So you have areas within with the external ear, the middle ear, and the inner ear that you can have alterations. The first one we'll talk about is the external ear. And this is just the area that's right on the outside where you just get your hearing stimuli. So you can have earwax there, and you can have masses. So cerumen is another word for earwax, and that can cause a physical obstruction with the ear. You can also have a mass that can be insects, that can be a toy, that can be anything that's not supposed to be there. A mass is something that causes an obstruction within the ear. You can also have inflammation of the ear called otitis externa. Next, we'll move to the middle ear, and some alterations you can have there is barotrauma. So normally you see barotrauma in people that do deep sea diving or do air travel a lot. And this is a result of atmospheric changes that your body and your ear is not able to respond to quickly. So it causes an injury to the ear because there's no response function there. So you have barotrauma, and again, it results from mostly deep sea diving and from air travel. Next, you have inflammation. Again, you have otitis media. Again, this is a type of infection, and this is one of the most common disorders that you see within the middle ear. A lot of children get ear infections, and some adults with certain allergies, of course, they get inflammation in the ear from that. You can get mastoiditis as well, which is also a type of infection that's streaming from the mastoid in the mouth, and it travels up to the ear. You have otosclerosis, and that is a genetic condition, autosomal dominant, and we'll talk a lot about what that means as far as autosomal dominant in a different chapter. But just know that that is a genetic form of a disease, autosclerosis, and this is the formation of spongy bone at the foot plate within the ear. And what this does is that it impairs the conduction and vibration of sounds, which basically damages the ear or muffles the sound within the ear. It is a chronic condition, it's progressive, and again, it does cause hearing loss. We have the inner ear, and you can have neural dysfunction such as tinnitus with the inner ear. And what tinnitus is like a ringing or the whistling in the ears, and it could be caused by noise-induced hearing loss, or you may have heard very loud sounds, like such as from bass, with music, or just at a concert even. So you can have a ringing or whistling in the ears after that loud sound stimulus has left. You can have presbycusis, and this is hearing loss, but this is more so associated with aging. So it's a chronic issue, and again, it normally happens with individuals that are aging, and it can be a result of hypertension, atherosclerosis. You can also have individuals with traumatic brain injury or ear infection or ear inflammation that has this tinnitus as well. You have equilibrium disruption, and again, this has a lot to do with your balance and your vestibular function. So individuals with Meniere's disease normally have tinnitus and hearing loss, and it is a type of vertigo, if you will. So vertigo is a spinning sensation where you don't feel like you're balanced. So Meniere's disease is associated with all of that, and it is associated with the overproduction or decreased absorption of endolymph. Last but not least, you have the labyrinthitis, and that is a type of inflammation of the internal ear, and it normally precipitates severe vertical and sensorineural hearing loss. So again, all of these things can happen with your ear, and it's all about location. So if we discuss tinnitus, that's more of an inner ear. Meniere's disease, that's an inner ear issue, versus then obstruction, that would be considered an external ear issue. So make sure you know the differences between what happens in the external ear, middle ear, and inner ear. So next we'll talk about the different types of hearing losses and their classification, and we'll talk a little bit about our hearing screening. So you do have different types. You have the conductive hearing loss, which is a localized hearing loss to the outer or middle ear or external or middle ear, and it can be temporary or permanent. Sensorineural is a hearing loss, is a type of permanent hearing loss, and normally it results from trauma, genetic inheritance, or diseases. So normally it is a defect of your cochlear nerve cells, and this is an issue of the internal ear, and normally your cochlear nerve or your auditory cranial nerve is involved. That's cranial nerve 8. Sometimes you have a mixture. So you can have a mixture of conductive hearing loss and sensorineural hearing loss, and all it is that it's a mixture between the two, depending on the cause. And you also have central auditory processing disorder, and this is a disorder that involves altered auditory signal processing in the brain. So again, this has more so not necessarily to do with your ears not functioning, but it's just your brain is not processing those hearing signals appropriately. When we do discuss hearing, we talk about acuity in decibels. And we also talk about the frequency or pitch in hertz. So individuals can hear at different frequencies or pitches, and we discuss that as hertz. So individuals that can sing or can play by ear with music, they're able to hear these different frequencies or pitches, and they're able to mimic those pitches into the sounds that they either sing or play. So they do that with the level of hertz that they are hearing, and their brain is able to process that very well. As far as your acuity, that's the amount of decibels or area that you can sense or hear clearly. So frequency and pitch has more so to do with the sound component, whereas acuity is how distinct is it. Again, when we look at our hearing screening, we do look at both acuity and frequency, and then we place what we find within these classifications of conductive, sensorineural, mixed, or central auditory processing disorder. So again, you have all kinds of hearing screenings, and just kind of understand what the differences are between the different classifications. So here we have the evaluation of the middle and inner ear. Normally we use tympanometry to evaluate your middle ear, and we also use an acoustic reflex measurement. In the inner ear, we use pure tone bone conduction, vestibular evoked myogenic potential test, and a otoacoustic emission. So when we're looking at this, these are just different diagnostics, if you will, to help service your middle ear or your inner ear. I'm not necessarily testing you on those specifics, but these are just good to know. So the next thing we'll talk about is taste. And again, we'll talk a little bit about what taste does. And again, it's the sense of taste on the tongue. And then we'll talk a little bit about the alterations that are associated with that. So this one's pretty easy to understand. When you deal with taste, it's on the tongue, and normally we have chemoreceptors, and it also involves the use of smell. But normally our taste buds are the receptors that help mediate our sensation of taste. And we have several types of sensations. We have that sweet taste, we have salty, bitter, we have sour and savory, all kinds of tastes that we are able to distinguish. It's important to know that taste, when we have a disorder in our taste, it often involves a disorder in the smell as well. So some disorders include phantom taste perception. You may even have a lingering and unpleasant taste that does not go away. You may have the reduced ability to taste one or all of the 5 basic types of taste. So that's the sweet, sour, salty, bitter, and savory. You're unable to determine which is which between the two. Or you may have a distortion of flavor, such as like a persistent metallic taste. But it's good to know that sometimes when we have that metallic taste, especially, it may indicate some other dysfunction overall within the body. So it's something to pay attention to. So next we'll talk about how taste is processed. Similar to the ear and similar to hearing and even seeing, we have a process that sends a signal to the brain. So you have the stimulus of a taste receptor on your taste bud, and that signal is transmitted through the facial nerve, cranial nerve 7, and also that glossopharyngeal nerve, cranial nerve number 9. And that signal transmits to the thalamus. So again, your thalamus has a lot to do with your sensory perception. So again, we see that with our hearing, and we see that with our pain, and now we're seeing that with taste. So now once it hits the thalamus, it produces a signal interpretation, and it goes specifically to the parietal lobe in the brain. You have a cortex called the gustatory, and anytime we talk about gustatory, that's just tasting. That's another word to describe taste. That gustatory cortex in the parietal lobe, and it helps determine the scent. It helps to determine taste. It helps to determine, even put together these other stimuli such as visual and thermal. And even if you taste something that's too hot, it actually helps you to determine that as well, the pain. So again, this is the process by which taste gets to your brain and sends that signal to help you determine what's going on with that particular food item. Next, we'll talk about smell, and again, we'll talk a little bit about how it works and then the alterations that are associated with smell. Anytime we talk about smell, it's dealing with our olfactory receptors. So we get a stimulus from the outside environment. It stimulates our olfactory receptors in our nasal cavities, and it is transmitted along the olfactory cranial nerve, and that is cranial nerve number 1. So it processes by sending those fibers to the olfactory bulb, and then it goes to the olfactory cortex within the brain. So we've talked a lot about how our different areas of the somatosensory and the special sensory functions work in the body, but here are our clinical models, and feel free to take out your disease cards or your syndrome cards and follow along as we discuss these different areas of alterations. So the first alteration that we'll talk about in clinical model that we'll talk about is fibromyalgia. So the pathophysiology is that it is not linked to a well-defined pathogenesis. So there's no definitive evidence of muscle pain or structural pain or functional alteration or even inflammation in individuals that have fibromyalgia. But there is a significance of pain in multiple areas of the body for these individuals. So they'll have neck pain, back pain, shoulder pain, hip pain, elbow pain. Sometimes all of these pains occur simultaneously, and there is a significant amount of fatigue and depression that coexists with this amount of pain because it's a chronic condition and they're not necessarily able to control it or treat it very well. As far as your diagnostic criteria, it's heavily dependent on subjective data. You have a history of fatigue. There is a chronic musculoskeletal pain, and it lasts at least 3 months in duration. As far as looking at the diagnostics, there is pain present in 12 out of 18 tender points for diagnosis. So there is a literal chart and a tall tale sign list that will point to diagnosis for this condition. There are different trigger points that induce pain to other parts of the body. So what that means is that when you touch one of these trigger points, it actually sends these painful stimuli throughout the rest of the body. So you have referred pain, whereas that is pain that is felt in the area that is distant from the source of the actual pain. So if I touch the individual's shoulder and they experience pain in their knee, that is very distant from the source of the actual pain, but it's referenced and it's there, and you cannot tell an individual that it does not exist. So we also have phantom pain, and this is pain that exists in an individual that does not have a limb or that limb has been amputated. So again, you cannot necessarily tell them that the pain is not there. They are truly experiencing this, and it has a lot to do with that gate control theory. It has a lot to do with those nerve endings firing off to the brain, and the brain has not necessarily processed that that limb and that area is gone yet. So you may see instances of phantom pain, but this is also a diagnostic criteria for individuals with fibromyalgia. As far as your treatment, of course, you want to do non-pharmacological methods and those pharmacological methods. And even that includes your antidepressant therapy. That's a adjuvant therapy, anticonvulsants. You may want to use analgesics. You may use opioids. And of course, the non-pharmacological methods are anything to help treat pain that's not a medication. And of course, you just want to maintain symptom management. Next, we'll talk about migraine headaches, and the pathophysiology is that they are recurrent, and normally they are moderate to severe in intensity, and sometimes they can last up to 2 days. Normally, you see migraine headaches in association with nausea, vomiting, and photophobia or sensitivity to light. And autophobia, sensitivity to noise, and it's most likely caused by neurological or biochemical events, and there are different triggers that can cause migraine headaches. As far as your diagnostic criteria, of course, you have to have a physical and a history examination. You have to have a CT head or MRI to get the acute state of it. It's not necessarily helpful to get it while the migraine is not happening. So a lot of times they try to get these CTs and MRIs while the migraines are happening. And again, there is a sudden onset. So as far as your treatment, you do want to prevent those triggers. Those individuals that have greater than 2 migraines a month, you want to use pain relieving medications that may include Excedrin or Furoset. You want to give them different options for analgesic treatment. And especially for those that continuously have them, you want to also consider non-pharmacological methods. If they're smoking, you want to encourage smoking cessation. Maybe there's a hormone instability, so you want to stabilize hormones, avoid triggers. Regular exercise tends to help. And if there must be some pharmacological methods, you may, again, consider NSAIDs or Tylenol, triptans and aspirin. Again, you may see CGRP receptor antagonists, and even anticonvulsants can help with migraine headaches. So here are those clinical manifestations. We have pain. Again, it's unilateral, and normally the pain is described as pulsing and throbbing on one side. Individuals will experience an aura or visual disturbances preceding the headache, and sometimes it is associated significantly with those migraine headaches. And then the prodromal symptoms or the actual manifestations of this could be mood changes, food cravings, and even constipation. Next, we'll talk about otitis media, and we'll talk about a couple of types here. We have acute otitis media, and that is an infection of the middle ear, and it's normally associated with upper respiratory infections, and there is an infectious fluid associated on the inside of the ear. We have otitis media with effusion, and this is also fluid in the middle ear, but it's not necessarily associated with infection or inflammation. So if you were asked the differences between the two, one is heavily associated with bacteria and pathogens and has an infected fluid, which is acute otitis media, whereas otitis media with effusion is just a fluid buildup that causes obstruction of the eustachian tubes in the ear. Then you have perforations, and this is generally a hole in the tympanic membrane caused by pressure in the middle ear. It can also be caused by trauma or inflammation. As far as your diagnostics, you want to look at the history of acute onset. You may even have an otoscopic exam. If there's an effusion, they'll see a tympanic membrane that is bulging. You may have limited or absent mobility, and there is a visible air fluid level. You may even have discharge or ear canal discharge called autorea. You may see inflammation in the ear, redness, erythema of the tympanic membrane, and then you may also have pain that interferes with activity and sleep. As far as treatment, it is based on an accurate diagnosis. You have to be able to tell if the ear fluid is infected versus non-infected. So again, acute otitis media is infected ear fluid versus otitis media with effusion. It's just regular fluid that's causing an obstruction. You have to observe these different types of ear infections for their frequency and how often that they're happening, and eventually what is it triggered by. And if it is infectious in process, then you want to treat that with analgesics and antibiotics. And here's a chart discussing the differences again between acute otitis media with effusion and a perforation. Again, otitis media is an infected ear fluid, and it's rapid in onset and short in duration, whereas otitis media with effusion is a fluid buildup. It can be acute, subacute, or chronic, but it's asymptomatic fluid, so you do not see pathogens or bacteria in the fluid with otitis media with effusion. And in perforation, there's a hole in the tympanic membrane, and it's caused by negative air pressure in the middle ear. It can be caused by trauma, such as somebody getting hit in the ear, or inflammation. So make sure you know the differences between the different classifications of otitis media. Clinical manifestations include your ear pain. You may see fever, enlarged lymph nodes in your periocular areas. You may see rhinorrhea, which is a runny nose. You may see a perforated tympanic membrane, impaired hearing. Otitis media with effusion is more associated with inflammation, whereas acute otitis media, you'll see recurrent episodes in this with inflammation, greater than 3 episodes in 6 months or greater than 4 episodes in 1 year. So this is Meniere's disease, and it is a classification of altered vestibular function, and it's caused by the increase of endolymph or lymph in your endosystem that leads to dilation of your membranes in the labyrinth of the ear, and eventually that dilation leads to rupture of that labyrinth, which allows the mixing of the endolymph and the perilymph. As far as your diagnostic criteria, you have a history of symptoms, which we'll talk about in a little bit. As far as your physical examination, of course, you have to have a auditory exam. They may even look at your auditory brainstem response in a glycerol test. They may do electrocalography, and caloric testing. As far as treatment, they'll do the management of your symptoms. They may regulate your body fluid. If you're smoking, they'll encourage smoking cessation and stress reduction. As far as pharmacological therapy, they may use diuretics and antiemetics for those that are nauseous with this disease. And for surgical correction, you may see vestibular neurectomy or labyrinthectomy to help remove the parts that are malfunctioning. Normally, Meniere's disease is a unilateral sensation, and it does depend on the severity, but you do see vertigo, nausea, and vomiting. You do see sensorineural hearing loss, pressure, and pain, and you may also hear tinnitus and nystagmus in this disease. So we have macular degeneration, and this is in the eyes. So you have degeneration of the fovea, and it's the central portion of your retinal macula. You have 2 different types of categories, and make sure you know the difference. When you have dry macular degeneration, that is atrophic. When you have wet macular degeneration, that's exudative. The main difference is that there is no treatment for the dry form or atrophic macular degeneration, but for the wet one, there is treatment. Normally, you have medications that help inhibit the wet form. As far as diagnostic criteria, you have vision screenings, and normally you do a ophthalmic exam, and they check for leakage, bulging macula, your drusen disposition, things like that. As far as your clinical manifestations, we'll talk about that in the next slide, but just make sure that you understand the difference between dry macular degeneration and wet exudative macular degeneration. Here are signs and symptoms. As far as the dry macular degeneration, it is a slow progression of symptoms, but again, there is no treatment for this. So once this progresses and it starts, there is no reversing that process. Whereas with the wet exudative, you do have treatment options. And as far as what it does, it is a rapid and severe onset of vision loss. And sometimes you'll even have dark or central spots within the retina that are present. You have decreased ability to read and recognize faces, colors, and you also have blindness that are associated with macular degeneration. And you have the general distortion of central vision with both types. So glaucoma is the result of vision loss due to your optic nerve damage, and you have different types. You have primary open angle, where the iris and the cornea meet, and you have impaired aqueous humor drainage leading to increased intraocular pressure, and that helps, well, it decreases your ability to have vision because that intraocular pressure is too great for the eye to sustain. Then you have angle closure, and that is rapid intraocular pressure that is blocked from aqueous humor drainage. You have normal tension, which is poor blood flow to the optic nerve. So all three of these can cause vision loss too if it's associated with that optic nerve. As far as your diagnostic criteria, they'll do some visual screening tests. They'll do your ophthalmic exam, of course, and they may even do tonometry to measure your intraocular pressure to see how susceptible you are to getting any of these types of closures. Um, as far as your treatment, you'll have medications that help increase your aqueous humor outflow and the fluid levels, and you may even have surgical corrections such as trabeculoplasty, trabeculolectomy, and idriosulectomy. As far as your signs and symptoms, clinical manifestations, with open angle primary, you have gradual irreversible vision loss. In your acute angle closure, you have induced intraocular pressure, and it's shown by increased pupil dilation. You have blind spots in the field of vision. You have eye pain, headaches, nausea, blurred vision. You may even see rainbows around lights at night. And of course, there is damage to that optic nerve leading to vision loss. Last but not least, we have the retinopathy of prematurity, and it happens in several stages, and it is based on the morphology of your retinal blood vessels. It is the impairment of your retinal blood vessels, and you have a couple of phases. You have phase one, where there's just arrested growth, so there's no growth happening at all, and then you have phase two, where there's unregulated growth. Either way, you have hemorrhaging and scarring that promotes retinal detachment, and you're not able to see through your retina. Um, as far as the diagnostic criteria, they do have several stages. I'm not necessarily testing you on these stages, but just know that this is a progressive disease, and you can flow anywhere through these multiple stages. So stage one is mildly abnormal vessel growth, but it may resolve. And most likely you can develop normal vision if you're in a stage one. Stage two, you have abnormal blood vessel growth, but you can also develop normal vision here as well. Stage three is severely abnormal blood vessel growth, and you have some develop normal vision and some don't. So this is where you have that middle of the road. You have stage 3+, and you have abnormal growth patterns. Sometimes they are enlarged, or they are contorted, or you have tortuosity with your vessels, and it requires early treatment to help prevent that retinal detachment. As far as stage four, excuse me, as far as stage four, you have partially detached retina, and it requires immediate treatment to save your vision. And then stage five is where you are completely detached and the retina comes off and you have hemorrhaging in the eyes. As far as treatment, you have laser treatment, cryotherapy, sclerobuccal, and you have vitrectomy. So again, these are all phases that you could potentially go through, and it is progressive, but if you're in that stage 1 through 3, you do have a possibility to not develop complications from this retinopathy. As far as your clinical manifestations, you have leukocoria, which is white pupils. You may see nystagmus, which is your abnormal eye movements. You may see strabismus, which is your crossed eyes, and then you have myopia, which is, in this case, would be severe nearsightedness. As always, make sure you review the chapter and the text, do your guided learning questions, complete your system disorder cards, review your case studies and activities. Make sure you review that and then quiz yourself, quiz others. Make sure you're able to answer your questions in the back of the test book. And if you're still not understanding, don't worry about that. You can always ask questions. I'll be more than happy to assist you. Thank you, and I look forward to seeing you in class.